Mga kababayan, ang pambansang awit ng Pilipinas.
Puso ko'y tinig ng kasayahan, dahil ako'y nasama sa tanan. Ang lahat may gintong nasa, makisig at masigla. Kapisanan ay tunay ang damdamin, suliranin itong baya'y pawiin. Ilalangin natin ang tapat sa may kapal ay lunas sa lahat. Awit ng DNA, tayo ay mag-iwan. Magtulungan, magunlad ng bayan. Ang kailangan, ibigay sa kanan, kalusugan at kasaganahan. Ang puso ko'y tigib ng kasayahan, dahil ako'y nasama sa tanan. Ang lahat may gintong nasa, makisig at masigla. Kapisanan ay tunay ang damdamin, suliranin itong baya'y pawiin. Ilalangin natin ang tapat sa may kapal, may lunas sa lahat. Ilalangin natin ang tapat sa may kapal, may lunas sa
Now let us welcome our OCMS President, Dr. Raymond Joseph Manso, for our opening remarks.
Good afternoon, everybody. During the week, we had a sort of mini workshop on multidisciplinary tumor board conference. After one whole week of activities during the Medicine Week celebration, we go right back at it with our monthly cancer advocacy lecture series, the third installment for this year. Even though almost 90% of thyroid cancers have excellent prognosis, it still takes a multidisciplinary approach in treating this disease. We all know that an MDT approach improves overall survival and decreases recurrence rates in all patients. Today, we will be fortunate to have experts in their respective fields to discuss the treatment options in the management of thyroid cancers. Thank you to our chair, Dr. Maricar, and to all our speakers and moderator who have shared their valuable time and expertise. Thank you to the Philippine Society of Endocrinology, Diabetes, and Metabolism in partnering with us in this activity. Welcome, everybody, and good afternoon.
Thank you, Dr. Manso. Now introducing our moderator. He took his Doctor of Medicine at pamantasan ng lungsod ng Maynila. had his residency training in internal medicine at James L. Gordon Memorial Hospital, and he was the chief resident from May to August 2015. He took his fellowship in endocrinology, diabetes, and metabolism at University of Santo Tomas and became the chief fellow from February to May 2016. He is a fellow of the Philippine College of Physicians, a diplomat of the Philippine Society of Endocrinology, Diabetes, and Metabolism, a member of the Philippine Thyroid Association, a member of Osteoporosis Society of the Philippines, and a member of American Association of Clinical Endocrinology. Dear doctors, we call on our new endocrinologist, the handsome gentleman, Dr. John Ryan Biar.
Hello, good afternoon, everyone. Thank you for the organizers of OCMS for having me here to be the moderator for this afternoon's presentation. Thyroid cancer is the most common endocrine malignancy in the Philippines, as mentioned earlier. No? It ranks 7th in overall malignancies, according to the latest data from the DOH. The incidence is 3 times more common among females. Risk factors include strong family history of malignancy and neck irradiation, among others. A hard mass in the anterior neck, rapid enlargement of a long-standing goiter, cervical lymphadenopathies, hoarseness, dysphagia, and difficulty of breathing are some of the signs and symptoms that should raise suspicion for thyroid malignancy. Despite having excellent prognosis in well-differentiated thyroid cancer, which is the most common, higher rates of recurrence and mortality have been observed among Asians, including us Filipinos, according to a local study, thus making thyroid cancer management a challenge even among experienced clinicians. We are honored to have 3 experts this afternoon to share their expertise in the management of thyroid cancer. So before anything else, some house rules, no? Keep the webcams off during the lecture. You may turn on your mic and your video during the Q&A portion. Keep yourselves on mute mode. And feel free to type in your questions and comments in the chat box for the open forum. So at the end of the 3 lectures, we will have an open forum wherein you can ask your questions. So for our speakers, may I introduce the first speaker, Dr. Rosario Bongco had her medicine from the University of Santo Tomas. He took her residency of internal medicine in UP-PGH. Then he took her fellowship in endocrinology, diabetes, and metabolism at the University of Santo Tomas Hospital and National University Hospital in Singapore. She is a fellow of the Philippine College of Physicians and a fellow of the Philippine Society of Endocrinology, Diabetes, and Metabolism. Currently, she is the chairman of the Department of Internal Medicine at ACE Medical Center in Bay Point. She is also an active consultant in James L. Gordon Memorial Hospital. Next speaker, we have Dr. Armand Cepeda. She graduated from the University of Santo Tomas, Faculty of Medicine and Surgery. She also took his residency training in general surgery in James Gordon Memorial Hospital. He obtained Master's in Management in the University of the Philippines Extension Program in Olongapo. He is a fellow of the Philippine College of Surgeons, Philippine Society of General Surgeons, and Philippine Society of Laparoscopic and Endoscopic Surgeons. Currently, he is a member of the Philippine Association of Training Officers in Surgery. And for the last speaker, we have Dr. Christopher Anthony Carbonell. He is a graduate of St. Luke's College of Medicine in Quezon City, and he took his training of internal medicine in San Juan de Dios Hospital, wherein then he pursued nuclear medicine at St. Luke's Medical Center. He is a fellow of the Philippine Society of Nuclear Medicine and the diplomat of the Philippine Specialty Board of Nuclear Medicine. He is an assistant professional lecturer at the Department of Physics in De La Salle University in Manila. He garnered an award for the outstanding teaching performance in major courses for the academic year 2012 to 2013. Currently, he is the head of the section of nuclear medicine at Bay Point Hospital and also the section head of the nuclear medicine in Parañaque Doctors Hospital. He also served as a counselor in the Pasay Parañaque Medical Society of the Philippine Medical Association. He is also a member of the Philippine Society of Nuclear Medicine, Philippine Medical Association, and the Pasay Parañaque Medical Society. So join me in welcoming our three distinguished speakers. So may I now call on Dr. Rose Bongco for the first lecture.
Good afternoon. Thank you, JR.
Good afternoon.
Yes, thank you, JR, for that kind introduction. So let me now share my slide. Can you see my slide?
Yes,
Oh.
clearly.
Yes, thank you, Denise.
Ah,
Ibalang ko yung boses mo.
love you.
Yeah. Good afternoon, everyone. Of course, thank you, JR, for that kind introduction. First of all, before I start, I would like to thank and congratulate our OCMS officers and board for a very successful week-long medicine week activity. Now, we're really very lucky to have a very hardworking set of officers and board. I would also like to thank them for allowing our society, the Philippine Society of Endocrinology, Diabetes, and Metabolism, of which me, JR, and Dr. Alani Asis are members, to collaborate in this worthwhile activity in celebration of the Thyroid Cancer Awareness Week, which is celebrated every 4th week of September. And of course, lastly, I would like to thank Dr. Mejia, Bustamante-Mejia, for chairing this activity and for the invitation. So, as mentioned, this afternoon we will be discussing the multidisciplinary approach on the management of differentiated thyroid cancer. And my task is to talk on the medical aspect of this treatment. So first, let me go on the global burden of thyroid cancer. This has been mentioned by JR, and this is data from the Globocan 2020 data, which is a global registry or database of cancer incidence and mortality. And as you can see in this pie chart, your thyroid cancer actually ranks 9th in terms of incidence. And this is global data. And it has a global incidence rate of 10.1 per 100,000 in women. And as is seen in most other thyroid condition, this is 3 to 4 times more common in women, and is actually the 5th most common cancer in women. And this has also been mentioned in the introduction. During the past 2 to 3 decades, we have actually seen a 2 to 3-fold increase in incidence. And this is brought about mainly by the increased diagnosis of your papillary carcinoma, including your papillary microcarcinoma. But the good thing is that in spite of this increasing incidence, as you can see on the graph at the lower portion of the slide, represented by your blue line, thus the death rate has remained stable. And this is represented by your red broken line. The death rate has remained stable at 1 to 2%, affirming the relatively indolent nature and good prognosis of this type of cancer. And with a 5-year survival rate of about 98%. So that is global data. And this is the Philippines Globocan data 2020, and highlighted in red would be your thyroid cancer. And it is actually included in the top 10 cancer in the Philippines. It, as mentioned by Dr. Villar, it actually ranks 7th. But if you can see, in terms of mortality, it actually ranks 21. And this is actually the only cancer. This is actually the only cancer in the list of the top 10 new cases that is not included in the top 10 in terms of mortality. It actually ranks way below at 21. So most of the data that I will be sharing this afternoon came from the 2015 American Thyroid Association guidelines on thyroid nodule and differentiated thyroid cancer management, as well as from the American Association of Clinical Endocrinology guidelines on thyroid nodule workup. So the most common presentation of your thyroid cancer is a thyroid nodule. And it can actually present either as a palpable nodule or as an incidental finding on imaging studies. And we are actually seeing more and more of this, what we call as thyroid incidentalomas. We're doing more and more imaging studies, ultrasound of the neck, carotid Doppler, and even chest X-ray may detect thyroid incidentalomas. And as mentioned, majority of these thyroid nodule, as much as 90 to 95%, are benign. And therefore, it is very important that a careful history, physical examination, as well as a detailed workup be done to avoid overdiagnosis. And majority of experts would actually recommend avoiding biopsy of most nodules less than 1 centimeter. Based on the history and the physical examination, there are several features that would suggest increased risk of malignant potential. And this would include your history of head and neck irradiation, family history of medullary thyroid carcinoma, multiple endocrine neoplasia, or even papillary thyroid carcinoma. Age less than 40 or more than 70 years are also suggestive of increased malignant potential, as well as male sex. And that is why we tend to be more aggressive in terms of workup and treatment of male patients with thyroid nodule. Growth of the nodule, firm or hard nodule consistency, cervical adenopathy, fixed nodule, and persistent dysphonia, dysphagia, or dyspnea are several other features suggesting increased risk of malignant potential. So illustrated here is a simplified algorithm on the workup of a thyroid nodule, since this is the most common presentation of your thyroid carcinoma. So it can, as I mentioned earlier, it can present either as a palpable nodule discovered by the patient or physician, or as an incidental nodule discovered on imaging and not clinically palpable. After a detailed history and careful physical examination, the recommended initial test would be a TSH, or thyroid stimulating hormone determination. And if your TSH is suppressed, the next recommendation is to do a radionuclide thyroid scan to rule out the presence of hyperfunctioning nodule. And I must emphasize that this is the only role of your radionuclide thyroid scan in terms of thyroid nodule assessment. And that is to rule out hyperfunctioning nodule, because for these types of nodule, FNA is not recommended, mainly because the chance of malignancy in hyperfunctioning or in hot or warm nodule is less than 1%. Okay? So if your TSH, on the other hand, is normal or high, then the next recommended diagnostic modality would be your ultrasound of the neck and the thyroid gland, basically to characterize your thyroid nodules. Okay? So these listed here are the different diagnostic modalities for the workup. As I've mentioned, TSH is done initially. If it's suppressed, you can request for your radionuclide thyroid scan to rule out hyperfunctioning nodule. And then if it's normal or high, you may request for your thyroid ultrasound. And depending on the features or characteristics of your nodule on the thyroid ultrasound, you may recommend doing a fine needle aspiration biopsy. Last on the diagnostic modalities, which I'll also be discussing briefly, would be molecular testing of your FNA sample, especially for those patients with indeterminate nodule. Okay, so there are actually two classifications that are used to evaluate the sonographic features of a thyroid nodule. First is this one, which is from the American Thyroid Association. So your American Thyroid Association classification makes use of a pattern-based system. This is basically 5 categories, each with increasing malignancy risk. As you can see on the bottom of the slide would be your purely cystic nodule. So it's basically an anechoic nodule. And for this situation, FNA is not recommended. since these purely cystic nodule are almost always benign. So FNA is not recommended. Although FNA may be done in cases of large nodules where compressive symptoms are present or obstruction, and that is basically done for therapeutic purposes and not for diagnostic purposes. So at the top of the graph or the picture would be your high suspicion nodule. And this is usually classified or characterized by the presence of your microcalcification, your hypoechoic nodule with irregular margins, and a taller than wide configuration. Highlighted at the lateral side of your sonographic pictures would be the cutoff size in recommending FNA. So for those nodules that are of low suspicion or very low suspicion, these are characterized by your spongiform lesions or your hyperechoic lesions with regular margins. The cutoff size is 2 centimeters for FNA to be recommended. However, for those with high suspicion features, as I've mentioned, microcalcification, hypoechoic nodules, irregular margin, FNA is recommended for nodules more than or equal to 1 centimeter. And for those intermediate suspicion, these are your hypoechoic nodules with regular margin. FNA is recommended for nodules 1.5 centimeter and above. The other type of classification, which is the more commonly used, since this is the classification used by most of our radiologists in reporting their ultrasound report, would be the one from the American College of Radiology TIRADS classification. So we are more familiar with this because this is the one usually reported. No? So this is a points-based system, also 5 categories, each with increasing malignancy risk. So depending on the feature, for example, the composition, the echogenicity, the shape, the margin, or the presence of echogenic foci, points are actually assigned, and these points are then added to determine the overall TIRADS level. So for example, your spongiform lesion would be assigned 0 points, whereas your solid lesion would be assigned 2 points. For echogenicity, hypoechoic lesions, which is usually associated with malignancy, are usually assigned 2 points. Taller than wide configuration is usually assigned 3 points. Extrathyroidal extension, 3 points, and peripheral calcification, 2 points. Of course, once added, the higher the points, the higher the malignancy risk. So TIRADS 5 would be those nodules with 7 points or more, and this is considered highly suspicious, and therefore FNA is recommended if the nodule is more than or equal to 1 centimeter. On the other end, your TIRADS 1 or TIRADS 2, which is actually 0 or 2 points, are usually benign conditions, and therefore FNA is not routinely recommended. These two methods, the ACR, TIRADS, and the American Thyroid Association, are actually superimposable, and they basically classify the nodules almost identically. So after a careful assessment of your ultrasound findings, the next step would be a fine needle aspiration biopsy, and this will then divide your lesions into either benign or malignant. And for our purposes this afternoon, we will be discussing the malignant lesions. So the 5 types of your thyroid cancer would be your papillary cancer, follicular, Hürthle cell cancer, medullary, and anaplastic. Although your primary thyroid lymphoma and metastatic thyroid lesions are not primarily thyroid cancer, they may also present as thyroid nodule, and therefore may also be included in the differential diagnosis. Okay, so for our purposes this afternoon, we will be talking on the management of differentiated thyroid cancer which includes your papillary thyroid cancer, which accounts for about 85% of the cases, follicular thyroid cancer 12%, and Hurtle cell carcinoma less than 3%. These three is actually grouped together or lumped together because their management is almost similar, and since they very well concentrate iodine. In contrast, your medullary and anaplastic, the management is different because they don't usually concentrate iodine. So just one slide on medullary thyroid. It arises from your parafollicular calcitonin secreting cells of the thyroid gland, and it can occur in sporadic and hereditary form. So your hereditary form would be associated with several gene mutations and commonly seen in your multiple endocrine neoplasia. It accounts for 2 to 3% of all thyroid cancer with a 10-year survival rate of about 75 to 85%. Whereas your anaplastic thyroid cancer is the most lethal, most aggressive thyroid gland malignancy. It accounts for less than 2% of all thyroid cancer and causes up to 40% of deaths from thyroid cancer. It has a very poor prognosis with a 5-year survival rate of less than 10%, and most patients die from the disease within 6 months to 1 year of the diagnosis. So just one slide on molecular testing. So after an ultrasound followed by your FNA, molecular testing may be done and may be used to guide care for patients with indeterminate nodules. So this is useful for those biopsy reporting as atypia of undetermined significance, follicular lesion of undetermined significance. So this may help for those specific type of patients. This may also be used to avoid unnecessary surgery, especially for cases of follicular lesion and Hurtle cell lesion. Because as we all know, the diagnosis of follicular carcinoma and Hurtle cell carcinoma requires the demonstration of capsular or vascular invasion. And we can only see this in histopath specimen. So molecular testing may be done for this follicular lesion or Hurtle cell lesions. In advanced stage of cancer, these can also be used as prognostic biomarkers. And this molecular testing can be done either as a single gene analysis or a broad molecular profiling. So the recommended one is the broad molecular profiling. The most commonly used in the US would be your ThyroSeq and the Affirma, which basically detects about more than 100 types of thyroid-related gene mutation. The difficulty or the issue with this molecular testing is, of course, first, the availability. This is not readily and commercially available in our country. And even though it's going to be available, the main difficulty or the main limiting factor would be its cost. It's a very costly examination. In the US, molecular testing would cost about $4,000 to $5,000 US. And that would, converting it into pesos, that would actually be more expensive than a regular thyroidectomy procedure. So there are several studies on its cost effectiveness, and in our setting, it's a question mark in terms of its cost effectiveness. So we'll now go to the management part. As mentioned, last Thursday, we had a multidisciplinary discussion on cancer approach. And this is actually one cancer where multidisciplinary approach is very important. Of course, the mainstay of treatment would be your surgery, and then your radioactive iodine treatment and long-term TSH suppression using levothyroxine. In certain advanced cases of your thyroid cancer, we may actually need the help of our radiation oncologists in doing external beam radiation therapy, or even the help of our medical oncologists using systemic therapy with the use of kinase inhibitor or even our usual chemotherapeutic agent. So what are the goals of initial therapy of differentiated thyroid cancer? Of course, first is to remove the primary tumor and then minimize the risk of disease recurrence and metastatic spread. And this is done by the use of your radioactive treatment and long-term TSH suppression. Next would be to facilitate post-operative treatment with radioactive iodine treatment. And this is where your completion thyroidectomy actually falls. No? Next would be to permit accurate staging and risk stratification of the disease and accurate long-term surveillance for disease recurrence. And this is mainly done through the use of your imaging studies, specifically your ultrasound and or whole body scan and your thyroglobulin analysis. And lastly is to minimize treatment-related morbidity. So this is the American Joint Committee on Cancer TNM staging 8th edition. And in this staging system, they basically stage the disease based on the size of the primary tumor, presence of extrathyroidal extension, presence of lymphadenopathy, as well as absence of presence of distant metastasis. And in this 8th edition, the cutoff age is actually 55 years. That is the main difference from the 7th edition, where the cutoff age is 45 years. So it actually looks like a busy slide, but I usually prefer this simplified approach. This is basically the same information, the 8th edition AGCC staging, but I find this algorithm easier to remember, especially for my patients. No? So what you need to determine first is the age at diagnosis. So if the age at diagnosis is less than 55 years, and then you have to detect or assess whether distant METs is present. If distant METs is present, then that is classified as stage 2 disease. If there's no distant METs, that is stage 1 disease. So for all patients less than 55 years, it's just basically a question of stage 1 or stage 2. No? So that's how good the prognosis for this disease is. For more than or equal to 55 years old, then you have to assess the presence of distant metastasis. And if it is present, then that is classified as a stage 4B disease. If there's no distant metastasis, the next thing that you need to assess would be the presence of extrathyroidal extension. If that is absent and the size of the nodule is less than 4 centimeters without nodal involvement, that is classified as stage 1. And if the nodule is more than 4 centimeters with or without nodal involvement, that is classified as stage 2. If extrathyroidal extension is present, if there's involvement of your strap muscles, that's a stage 2 disease. If there's involvement of your subcutaneous tissue, including your larynx, trachea, esophagus, and even the recurrent laryngeal nerve, that's a stage 3 disease, and your prevertebral fascia encasing the major vessels would be a stage 4A disease. This is another way of stratifying the risk based on the ATA recommendation. And in this risk stratification system, low risk would be those cancers that are just confined to your thyroid gland, whereas the high-risk nodules or cancer would be those with gross extrathyroidal extension, those with incomplete tumor resection, presence of distant metastasis, or even presence of metastatic lymph node, and even vascular invasion in cases of follicular thyroid cancer. So the mainstay medical treatment would be your TSH suppression using your levothyroxine. And the principle behind this treatment is that your TSH, as the term implies, thyroid stimulating hormone, it is basically a trophic hormone that can stimulate the growth of cells derived from the thyroid follicular epithelium. So any thyroid cells, be it benign or malignant, its growth is dependent on your TSH level. Okay, and therefore suppressing your TSH can potentially minimize the growth of these benign or even cancerous cells. Okay. However, caution in this form of treatment would be the associated potential toxicities with chronic or long-term TSH suppression. And this would include your cardiac arrhythmias, usually either in the form of sinus tachycardia or your atrial fibrillation, bone demineralization, and even overt thyrotoxicosis, usually presenting as significant weight loss, especially among our elderly patients. Because of the effect of your levothyroxine on your bone, adequate daily intake of calcium and vitamin D is recommended for patients with chronically suppressed TSH level. So just some practical tips on levothyroxine use. Levothyroxine is the recommended preparation of choice, mainly because of its increased efficacy, its favorable side effect profile, as well as its low cost. No? So napakamura niya compared to other medicines. So the initial replacement dose for benign condition would be a 1.6 to 1.8 microgram per kilogram. And for suppression dose, it's a little bit higher at 2.1 to 2.7 microgram per kilogram per day. Of course, this is just your initial dose, and your subsequent doses will then be determined by the regular monitoring of your TSH level and your desired or your target TSH level. So another important thing or practical tip on levothyroxine is that it has a long half-life, about 6 to 7 days. And therefore, it is given only once a day. There is no need to split the dose into 2 or 3 times a day, even if you're going to give a very high dose of 400 or 500 mcg. Because I'm occasionally seeing patients being given levothyroxine 50 twice a day, 53 times a day. There's really no need for this. It has a very long half-life, so once a day dosing is sufficient. Once a day dosing also has the advantage of improved patient compliance. Another advantage of this long half-life would be the potential to give catch-up doses. And this is what I usually tell my patients. Catch-up dose is when, for example, a patient missed their medications. For example, a patient went on a vacation on a faraway island and forgot to bring their medication and miss taking their medicines for 1 or 2 weeks. What I usually tell them is that on their return from their vacation, they may take their levothyroxine at double dose for the number of days that they miss their medication. So it's basically catching up for their missed doses during the 2 weeks that they were away. And it's possible, and this is mainly because of the long half-life of the drug, okay? Also, your levothyroxine is usually affected, its absorption is usually affected by food intake, and therefore the recommendation is to take it either 30 to 60 minutes before breakfast or at bedtime, which is 3 or more hours after the evening meal, for optimal consistent absorption. So listed here is a long list of drugs that can potentially interact with your levothyroxine. It can either increase, decrease your levothyroxine metabolism or even synthesis. Notorious in this list would be your antacids, your PPI, your calcium salts, calcium vitamins, even ferrous sulfates. So for those patients taking this drug, we usually advise them to take these drugs at least 4 to 6 hours apart from their levothyroxine. Other notorious drugs that has drug interaction with levothyroxine would be your anti-COX, specifically your rifampicin, your metformin, even steroids, and even your antidepressants. So for those patients taking this drug, you may consider monitoring their TSH level more frequently just to be sure that they are still receiving the right dose. So your TSH goal is actually tailored to the risk of recurrence and death from thyroid cancer. And this is from the American Thyroid Association recommendation. For those low-risk patients, the recommended TSH goal is 0.5 to 2.0, with 0.5 being the lower limit of your normal level. For intermediate risk, it's 0.1 to 0.5, and for high risk, it's less than 0.1. Although personally, in my private practice, for my low-risk patients, I'm actually not so comfortable with 2.0. So personally, me, for my low-risk patients, I still aim for 0.5 to at least 1.0. So I don't know with JR, what is his, would be happy to hear his opinion on this, okay? So for monitoring after the initial treatment, so after your surgery, radioactive, the monitoring that we usually do would be your thyroglobulin and your imaging studies, specifically your ultrasound of the neck. So your thyroglobulin is a glycoprotein molecule synthesized exclusively by your thyroid follicular cells. So there are no other cells in the body that can synthesize your thyroglobulin except cells of thyroid origin. And your thyroglobulin level is proportional to the volume of thyroid tissue in the body. And this is primarily used as a tumor marker to monitor treatment of differentiated thyroid cancer and detect recurrence. However, measurement of your thyroglobulin, you should also be doing simultaneous measurement of your anti-thyroglobulin antibodies, since these antibodies can be seen in as much as 25% of your thyroid cancer patients, and therefore may potentially interfere in the interpretation of their thyroglobulin assays. So the response to therapy is categorized into either excellent response, biochemical incomplete, structural incomplete, and indeterminate response. Biochemical incomplete would be those with elevated TG with negative imaging, whereas your structural incomplete would be those with positive imaging regardless of their thyroglobulin level. And excellent response or no evidence of disease is defined as negative imaging, and for most patients, the imaging modality of choice would be an ultrasound of the neck. So that is sufficient. If your TG levels are suppressed, then ultrasound of the neck is sufficient. However, if your thyroglobulin levels are elevated, you may opt to do additional imaging studies such as your whole body scan or even your PET scan. So excellent response is defined as negative imaging and either suppressed TG or suppressed TG of less than 0.2 and a stimulated thyroglobulin of less than 1 nanogram per ml. So what is suppressed thyroglobulin? Suppressed thyroglobulin is thyroglobulin determination taken while the patient is taking levothyroxine. So you don't stop the levothyroxine, just ask them to do thyroglobulin and TSH determination. And the cutoff for that is 0.2. Whereas for your stimulated thyroglobulin, we usually tell the patients to stop or withdraw their levothyroxine for 2 to 4 weeks and then do their TSH and thyroglobulin. And for that stimulated TG, the cutoff is less than 1 nanogram per ml. And for patients with excellent response, this is also associated with a good prognosis with about 1 to 4% recurrence and less than 1% disease-specific death rate. So what are the goal of long-term follow-up? Of course, first would be to accurate surveillance for possible recurrence. And second, since you'll be using levothyroxine at high supraphysiologic doses, is to monitor thyroxine suppression or replacement therapy to avoid under-replacement or overly aggressive therapy. How about for metastatic disease? So this is the preferred hierarchy, and this should be in order of treatment for patients with advanced or metastatic disease. First is surgical excision of locoregional disease, if this is surgically feasible, followed by your I-131 therapy for RAR responsive disease, and then external beam radiation therapy or other directed treatment modalities as the case may be. And then your TSH suppressive thyroid hormone therapy for patients with stable or slowly progressive asymptomatic disease. Lastly, you may also opt to give for advanced metastatic disease systemic therapy using kinase inhibitors for patients with significantly progressive macroscopic refractory disease. So kinase therapy, this is exemplified by your sorafenib and your lenvatinib, and this has FDA approval for this indication. They can be considered in radioactive iodine refractory differentiated thyroid carcinoma or for tumors that are not surgically resectable. Although I should emphasize that although this can be associated with improved progression-free survival, this is not curative, and this may be expected to cause side effects that may have a significant effect on quality of life, including diarrhea, bleeding, hypertension, stroke, and liver toxicity. And that's have been reported in the literature. So a detailed discussion with the patient is necessary before starting this form of treatment. So in summary, we have seen increasing incidence of thyroid cancer in the past 2 to 3 decades, mainly due to the increasing diagnosis of your papillary carcinoma. The good thing is that death rate remains stable at 1 to 2%. Thyroid nodule is the most common presentation of your thyroid carcinoma, and initial evaluation includes your TSH, thyroid ultrasound, and fine needle aspiration biopsy. A multidisciplinary approach is necessary, and the mainstays of treatment would be your surgery, radioactive iodine therapy, and long-term TSH suppression using levothyroxine. For post-op monitoring or for monitoring after the initial therapy, we may do our thyroglobulin analysis together with our anti-TG antibodies and neck ultrasound. And these are usually done periodically to detect recurrent or residual disease. So that is my last slide. Thank you very much for listening.
Thank you very much, Dr. Rose Bongco, for that
Thank you,
very comprehensive and informative discussion. For me, Doktora, regarding po dun sa comment
Target.
regarding the TSH suppression, in my practice, it depends on the presentation of the cancer and the age of the patient. If the patient presents with an extensive or advanced thyroid cancer, I would go to a more suppressed po na TSH, lower than 0.1 or lower than the lower limit of normal. But if the
for low risk, that's
kapag low risk lang, Doktora, nasa ano lang, nasa lower limit of normal lang.
Oo, 0.5, no?
Especially
Yes.
if the patient is an elderly at risk for osteoporosis, I also add calcium tablets then, Doktora.
Yes. Thank you.
So reminding again everyone, for your questions, you may key in the chat box provided to be answered later on at the end of the third lecture. Moving on, may we now call on Dr. Cepeda to discuss the surgical management of thyroid malignancies.
Good afternoon. Can you see my slides?
Yes.
Yes, Doctor.
Yes.
I have 45 slides, but this already reduced into half because of the lecture of Doctora. Salamat po. So overview. How common are thyroid nodule? Workup for new thyroid nodule, the guidelines and recommendations, the initial treatment of thyroid cancer, and the role and extent of surgery in thyroid cancer. So most of the thyroid nodule epidemiology was already given by Dr. VR and Doctora. So salamat po. Wala na masyadong madadagdag. I just want to emphasize that thyroid nodules are common but mostly benign. on our part, how would you separate the benign from suspicious? So just like other specialty, we have to start from history. We have history of excess thyroid hormone or hyperthyroidism, family member with thyroid CA, endocrine disorder, radiation exposure. This does not include the X-ray, CT scan, or dental X-ray. This is most likely from children from previous treatment of other disease like lymphoma. Most thyroid nodules are painless, and also most thyroid cancer is painless also. However, large nodule around 4 centimeter or more can have compression and have symptoms that was dysphagia, dysphonia. We have to do our physical exam. We have to feel for the neck, feel for the lymph node. It's firm, fixed, the adjacent structures associated within large regional lymph nodes. There will be a vocal cord paralysis or compressive symptoms. So to have to request for laboratory for thyroid function test. However, history and exams are not accurate to detect cancer. So ano pala? So ultrasound and biopsy are the key for diagnosis. Ultrasound is a must in evaluation and treatment of thyroid cancer. The advantage of ultrasound is it has no radiation exposure. It is cheap, it's commonly available, easy to perform. However, the disadvantages are operator and machine dependent. So there's an increase in inter-observer variability, greatest variability in reporting. So we need a machine that are having good resolutions or image. Most patients do not need any other imaging. There are lots of advantages when surgeons do their ultrasounds. No? So in this part, the PCS had an arm of passus wherein surgeons are trained to do their bedside or office ultrasound. The ultrasound aids in critical decision making. Here are the features of thyroid cancer. So hypoechoic, regular margins, calcification taller than wide, just as discussed. And also we have to ask our patients if they have previous ultrasound. So we have to measure for the growth and also the evaluation of the lymph nodes. This is already discussed. And the thyroids. So the next is, do all thyroid nodules need biopsy? And the answer is, it depends on the ultrasound findings in the size and suspicion. So we recommend no biopsy in less than 1 centimeter with the rare exceptions. So the exemptions are those who have highly suspicious of malignancy. Number 2, also, we don't need biopsy in purely cystic nodules. And yes, we'll do our biopsy in tumors with greater than 1 centimeter with intermediate suspicion or greater than 1.5 centimeter with low suspicion. And we consider biopsy greater than 2 cm in a very low suspicion. This is to avoid the over-treatment. Ultrasound-guided biopsies yield on thyroid malignancy is better than palpation-guided. No? So ultrasound the FNAB should be done with the ultrasound. This it brings us high yield, especially if the tumors are posteriorly located and small nodules. So before, if the patient have thyroid nodule, the only way to know if it's malignant is to operate on them. Now with the FNAB, the number of operations was decreased into half. What are the results of the FNAB? No? The FNAB, the Bethesda classification, standardized the reporting, and this will be benign, non-diagnostic. It doesn't mean that this happens when the cyst aspirated is almost entirely composed of blood. So blood aspirate, no? So all you have to do is to repeat an FNAB. Benign, no malignant features. So this is already explained by Doctora, the intermediate or suspicious. On our polycardioneoplasm or itong AUS, FLS, yung may atypia, these are the intermediate, no? Usually we just repeat the biopsy since we cannot afford to do the molecular testing on this one. Sabi nga, syadong expensive and not readily available in our setting. Pero in case na, if we will do that, the results of this will give you a benign features or suspicious. So, tahatiin niyo lang sa dalawa. So, usually yung benign, just observe. How about the suspicious? You have to still undergo for surgery. Again, this modality will just avoid the overtreatment. These are the 4 types of thyroid malignancy. The mortality is still 1 per 200 patients, and most are stable for 3 decades. No? So, since papillary and follicular are most common, most of my lectures will regard on the differentiated thyroid CA. So thyroid CA, most common endocrine malignancy, more common in women, but more aggressive in men. This is already shown by Dr. Rose Bongco. So what is the role of surgery? Surgery is still the mainstay in the treatment of thyroid cancer. So if we talk about surgery, of course, we cannot escape the anatomy. So this procedure, on this picture, I just want to tell you that the thyroid gland is very vascular. In fact, the approximate flow rate is 560 ml per 100 grams of tissue per minute. This is a flow rate per gram that is second only to adrenals. However, a thyroid gland will just weigh around 15 to 25 grams. On the right side is the lymphatic representations of lymphatics, no? So yung mga lymph nodes. This is also important for us. The principles of thyroid surgery does not change for the past 500 years. No? So it still holds today. And these are the ligation of thyroid vessels, preservation of parathyroid glands, identification and preservation of the recurrent laryngeal nerves. Of course, there will be a problem post-op. No? So there might be a bleeding. An injury to the parathyroid will give you a hypocalcemia, and a nerve injury to the recurrent or the superior laryngeal nerve. How do we approach or operate the thyroid cancer? There are a lot of recommendations available for us. This one is from PJSS, but this is dated from 2013. So we still read on that. NCCN, wherein the updates, we update it yearly, annually, and ETA. By definitions, the guidelines cannot incorporate all possible clinical variations and are not intended to replace a good clinical judgment of individualization of treatment. And with regards with this ETA 2015, I can say that there's a new respect for treatment-related morbidity, the risk and that comes with the treatment that we provide. These guidelines provide the importance of weighing the benefit over the possible risk, and to make sure that patient will make the best decision when the different alternatives are possible. So These are guidelines. These are all guidelines, and the final decision depends on the patient and the doctor working together. So in surgical part, we have lobectomy, where one lobe is taken out, total thyroidectomy, or total thyroidectomy with lymph node dissection. The lymph node dissection could be a central or the lateral. Central with the level 6. So when is lobectomy alone sufficient? Tumors less than 1 centimeter unifocal, no extrathyroidal extension, no clinical lymph nodes, no prior head or radiation history, no familial thyroid history, less aggressive histological subtypes, and of course, patient's preference. The rationale for lobectomy in low risk is to avoid hormonal requirements. After all, the more aggressive surgery does not improve prognosis. And also, this decreases the surgical complications. When is total thyroidectomy performed? Tumors greater than 4 centimeter, extension beyond the thyroids into adjacent structures like the trachea, the muscles, and the esophagus. There's a clinical spread to local lymph nodes and distant metastasis. This enables to remove the tumor on the other lobe, enables treatment with radioactive iodine, and enhances surveillance with a tumor marker like the thyroglobulin. What about 1 to 4 centimeter? This is still controversial because of the evolving clinical practice. But the primary suggestion is to do only a lobectomy. And of course, this should be individualized. This should be explained to the patient. We must have good ultrasound cytopathologist, a trusted surgeon, and patient's preference. How about lymph node dissection? Lymph node dissection could be divided into two, a therapeutic and a prophylactic. Therapeutic for palpable and image abnormal lymph nodes with proven cancer. We also do to prevent therapeutic to prevent local tumor invasion, complication, and possibly improve survival. And the dissection should be compartment-based. How about the prophylactic? Doing a lymph node dissection which are negative for PE in imaging. Removing undetected microscopic disease may prevent later recurrences and reduce the need for operation. Again, these are compartment-based. What do the guidelines say about central lymph node dissection? As you can see, the ATA 2015 will recommend the central lymph node dissection for TT-T4 tumors or clinically involved lateral nodes, or if information will impact further surgery. The European Society of Medical Oncology also consider a TT-T4 to improve local control. The NCCN and the American Association of Endocrine Surgeons does not recommend a prophylactic central node dissection. How about the lateral neck dissection? What do the guidelines say? The ATA and the AAES recommend neck dissection to include 2A, 3, 4, and 5B. And these are for the biopsy-proven metastatic PTCA. The NCCN for clinically positive and biopsy-proven nodal metastasis. And the dissections include level 2, 3, 4, and 4B. The extent of dissection, including 1A and 1B, when clinically involved. So what management comprise the management of thyroid? Say again, surgery. This comprise of lobectomy, a total thyroidectomy, and a total thyroidectomy with or without axilla, with or without lymph node dissection. And do we recommend radiation iodine ablation? So, should be considered tumor more than 4 cm, extrathyroidal extension, microscopic, central node metastasis greater than 2 cm, and lateral lymph nodes metastasis. And this should be recommended for extrathyroidal extension in distant mets. Hormone suppression was already discussed by Dr. and the follow-up. So in conclusion, thyroid nodules are common but mostly benign. Surgery remains the mainstay in the thyroid cancer. Surgery extent is individualized. The guidelines for thyroid cancer treatment are evolving. If you will allow me, I still have 4 slides regarding the minimally invasive thyroidectomy. Because I saw this in the discussions a while ago sa TICAS. So the role of minimally invasive thyroidectomy. So we have 3, the minimally invasive video-assisted thyroidectomy, the VMAT, the transoral endoscopic thyroidectomy or TUET, and the robot-assisted transaxillary thyroidectomy. So I'll just give you 4 slides. These are the new in minimally invasive thyroidectomy. So they just put 3 trocars here, and on this port, they're going to do the operation. This is an excellent cosmetic result. 1.5 cm scar only. The outcomes are comparable with the conventional. However, these are indicated only for 3 to 4 cm nodules and low-risk papillary carcinoma or smaller size. The transoral endoscopic thyroidectomy. No? This is considered as the true scarless thyroidectomy. This is also comparable to conventional. Central neck dissection can be done. However, the malignant nodules greater than 2 centimeters is of limitations. No? Because of the ability to extract the specimen without compromising the specimen. So this one, our colleague, Dr. Domingo Sampang from Bataan, are doing this transoral endoscopic thyroidectomy. And the last is the RAT, or robot-assisted thyroidectomy. However, the applications of these minimally invasive procedures in thyroid cancer management is limited. So we still have to get data, more data. And since the procedure is still young, and the problem with this is due to the limitations in doing a cervical lymph node dissection. So, conclusion, conventional thyroid surgery is currently the gold standard when it comes to surgery of thyroid cancer. Minimally invasive techniques have yet to achieve the intraoperative flexibility, visualization, and long-term outcomes of conventional thyroidectomy. That's my slides. Last slide. Thank you.
Thank you, Dr. Cepeda, for giving us a walkthrough to that very innovative surgical treatment for thyroid malignancies. Moving on, for the last lecture, we will now call on Dr. Carbonell for the nuclear management of thyroid malignancies.
Sorry for that. I just had a little technical glitch. Hello, can everybody hear me now?
Loud and clear,
Yes,
Doctor.
sir.
Okay. So, hello everyone. You may call me Dr. Chris. At the risk of being repetitious, thank you very much for inviting me to share the contribution of nuclear medicine specialty in the management of thyroid cancer. Tonight, I will be presenting about the basics of radioactive iodine treatment in thyroid malignancy. Let me introduce that nuclear medicine is the specialty that performs this particular treatment protocol. Well, nuclear medicine is the specialty that performs this particular treatment protocol. I'd like to introduce to you that iodine 131 is the main radiopharmaceutical used for this kind of treatment. And predominantly, it emits a form of a medium energy beta rays, which is a very ideal form of energy for causing death of cells because it radiates cells up to 7 meters. Furthermore, its energy emissions are there are also extra energy emissions, which are your gamma rays, which are also suitable for diagnostic imaging. And I'd like to reiterate that the thyroid absorbs iodine 131 like non-radioactive dietary iodine. Patients with differentiated thyroid cancer usually are given high doses of iodine 131. And from the picture below, you would see here a post-RAI body scan of patients diagnosed with differentiated thyroid cancer with metastatic sites in the different parts of the body. This was discussed by Dr. Rose Bongco earlier, so I will not deal too much with this particular subtopic of mine. But nonetheless, it's very important to note that since the differentiated type of cancer represents more than 90% of thyroid malignancies, that only means that your radioactive iodine treatment can be applied to more than 90% of patients diagnosed with thyroid malignancy. This particular slide are the usual candidates for RAI therapy, wherein papillary and follicular variants are commonly concentrated by radioactive iodine, and your tall cell and columnar cell variant of papillary, as well as your Hurtle cell and your poorly differentiated variant, could also be treated by RAI therapy in most of the time. But remember that your anaplastic and your medullary variant will never concentrate radioactive iodine. So indications for RAI treatment in differentiated thyroid cancer are the following. And these are tumor sizes more than 1.5 centimeters, as well tumor sizes below 1.5 cm, but there is unfavorable histology, which is your tall cells, sclerosing, or other aggressive variants. Okay. Patients diagnosed with lymph node metastasis, histology character or of multifocal disease, which could represent intrathyroidal metastasis, lymphatic or vascular invasion, capsular invasion or penetration, including perithyroidal soft tissue involvement, metastasis to lung, bone, liver, brain, and the like. So the amount of iodine 131 decreases to half every 8 days, which is the physical half-life of this radiopharmaceutical. So what happens after iodine 131 is administered to a patient? Okay, so that iodine 131 will be excreted by the body via the renal, sweat glands, through the feces, which now decreases the elimination at a much faster rate. And that is actually the biological half-life of iodine 131 as compared to the physical half-life of your iodine 131, which is 8 days. Obviously, if you're considering, or if biological half-life comes into play, there will be a rapid clearance of this particular isotope in the body. How is iodine 131 administered? It is given orally, either in capsule or solution form, and frequent oral fluid intake is advised to increase output. There will be some cases where patients on parenteral nutrition or on NGT feeding are given intravenous fluids to increase urinary output. Do all patients under iodine 131 therapy will require confinement? In the Philippines, only patients where activity of 15 millicurie or more will need confinement of at least a day to comply with the PNRI regulations to prevent unnecessary radiation exposure. What type of confinement is allowed? In terms of confinement type, patients are usually admitted in an isolation room where there is lead wall lining. You can also see here from these photos that inside the room there would be installations of lead screens and lead shields, and trash bins are also lined with lead. And as the photo depicts here, a restroom is also lined with the plastic for easier decontamination process. As the patient's body fluids and waste are excreted in the urine, feces, saliva, and sweat, the following safety measures must be observed. Flushing the toilet at least twice after use is recommended. It is also advised to the patient that he or she avoid spitting. Using of own utensils and washing them thoroughly after use is recommended. Preferably if the patients can have disposable utensils, that would be better. Washing underwear separately, at least during the stay in the hospital. And avoiding close contact with pregnant women and children for a few days is also recommended. Patients may receive visitors except children and pregnant women during visiting hours and in a specified duration. We will discuss more what I mean by a specified duration in the next slide. When can a patient go home? A patient who receives an iodine 131 below 15 millicurie is treated as an outpatient. However, if patient is treated as an inpatient, he or she may be discharged once the radiation count is equal to or less than 2.5 millirads per hour. This particular formula is used to estimate the time or even consider the specified duration that I was mentioning earlier. And this will tell you, or the result of this particular formula will tell you the time that the nurses or our healthcare workers should maintain when they are conducting necessary procedures to the patient. The numerator 2 is actually the acceptable radiation or dose rate meter that I have shown in my previous slide for patient to be given the go signal for discharge. But if you can remember from the previous slide, I have stated that the radiation count should be 2.5 mR per hour. It was used in this particular equation as to give necessary window for safety of our healthcare workers, since the radiation being emitted by the radiation source, which is the patient, is instantaneous. So even though if that nurse or healthcare worker exceeds a second or a minute in duration when he needs to approach the patient within 1 meter, there's still a window of safety for him to have when you are computing the nursing time in this particular using this particular constant value. To better understand how iodine 131 is absorbed in the thyroid follicular cells, I will be showing to you some a short or brief concepts in the thyroid hormone production. But also, it is also important to note here that your iodine 131 will just undergo two important steps in the entire thyroid hormone production physiology. And this is particularly the initial step, which is iodide trapping, okay? And the last step, actually, where your iodine 131 will undergo is the organification. The rest of the final steps will be skipped by the iodine 131, since it will decay through time, and these final steps will not be undergone by the iodine 131 anymore. So that would be coupling, the uptake to thyroglobulin from the colloid, and definitely the release of your T4 and T3 in the circulation. What I have here is a cumulative survival or inverse mortality for a 20-year period of high and low risk carcinoma patients of the thyroid. The risk here is assessed by the vascular invasion and presence of lymph nodes, and it is just important to note here that in low risk patients, you would see that there is a almost stable risk of patients I'm sorry. Okay, so this particular table shows that the downsloping of patients in low risk, identified as low risk, okay, years after initial treatment, okay, you will have a very stable downsloping of the risk. While patients classified as high risk, there is a very deep downsloping of the cumulative survival rate, okay, for those who are classified as high risk. This particular table shows that patients being treated with radioactive ablation have a very have a relative low cumulative recurrence of the disease, and patients who were not treated with radioiodine ablation have a very high cumulative recurrence rate of recurrence. And on the table below, or the graph below, patients who were not treated with RAI ablation have high cumulative death rate as compared to patients who have treated with RAI, who have almost zero cumulative death rate for about 35 years. In this particular table, it just shows that the highest organ exposed to radiation is your bladder wall if the patient is thyroidectomized. Sorry. Hence, the patient is advised to drink plenty of water, not only for purposes that patient can go home right away, but to decrease the exposure of ionizing radiation to the bladder wall. For patient preparation, for patients who are unable to tolerate tolerate hypothyroidism symptoms, they're usually given recombinant TSH. Okay, and usually the procedure is explained, as well as the treatment, the complications, side effects, therapeutic alternatives, and the expected outcome to the patient. These are all given in an informed consent where the following parameters are also should also be discussed to the patient, wherein more than one treatment is necessary, and there will come a time that there will be lifelong daily ingestion of your thyroid hormone. Early adverse effects may be encountered, such as gastritis, neck swelling, sialadenitis, or parotiditis, and long-term follow-up of patients will be necessary. In patients who will have to undergo radioactive iodine treatment, especially for thyroid cancer patients, it is very important to note that thyroid hormones are withdrawn for at least a month. And if patient is going to undergo CT scans with iodine-based contrast, it would be prudent to postpone the procedure for at least a month. So if this particular diagnostic protocol is needed, I would advise that the diagnostic CT scan, in diagnostic CT scan, the contrast that you are going to use should be non-iodine based. When I speak of putting the patient in low iodine diet, I mainly advise them to shy away from seafoods for at least 2 weeks to increase the sensitivity or effectiveness of your radioactive iodine to your thyroid residuals. So for perioperative staging, the lymph nodes in the neck are evaluated by neck ultrasound and MRI. Lung metastases are assessed by doing CT scan. And again, I would like to reiterate this. If you're considering iodine 131 treatment, immediately after, non-iodine based contrast is recommended. So chest x-ray could also be done. For bone metastasis, bone scan or skeletal x-rays should also be reviewed. So the early adverse effects of radioactive iodine treatment includes mucositis, nausea and vomiting, pain and tenderness in the salivary glands, loss of saliva or taste, neck pain and swelling, decreased WBC. This particular adverse effect, actually, there's a study done by a colleague of mine back in 2007 in PGH, which showing transient and gradual return to pre-treatment values of your WBC within 3 months after treatment. So furthermore, expected early adverse effects are your reduced taste or hypogeusia, dry eyes, and epiphora. For the probable late adverse effects, there are 2 common adverse effects that you need to consider or expect in radioactive iodine treatment. This particular adverse effects, there are no hardcore studies that will prove or validate yet this studies or this side effects, because the long-term side effects are too long for you to create a very reliable study to implicate radioactive iodine treatment as a direct cause for this particular late adverse effects. And these are mainly your infertility. In fact, in a study done by Vini in 2002, there's the risk of permanent damage to the ovaries after ablative radioiodine treatment appears to be very low, and patients can be reassured that they can have normal pregnancies after this treatment. And the women treatment with 150 millicurie of iodine 131 had subsequent fertility histories similar to those of women with thyroid cancer who were treated with surgery alone by a study done by Dr. Rini back in 1995. And a more recent study just last April 2021, wherein most of the studies indicate that RAI therapy for differentiated thyroid cancer is not associated with a long-term decrease in pregnancy rates. For the development of other malignancies, secondary tumors were not observed with statistically significant increased frequency in women who received 150 millicurie of iodine 131 by the study done by Dr. Rini in 1995. And a large population basis analysis, low percentage of different thyroid cancer survivors would develop secondary malignancy during follow-up in a study done by Xiaoran Mei just this year, 2021. And another study wherein the risk of secondary primary in thyroid cancer survivors treated with RAI is slightly increased compared to thyroid cancer survivors not treated with RAI by Sauka back in 2009. How much iodine 131 activity should be given in thyroid CA? For post-operative ablation of thyroid remnants, usually in practice, nuclear medicine specialist would give 75 to 150 millicurie. However, ATA guidelines of 2015 would suggest a dose activity of 30 millicurie. For nodal metastasis in the neck or mediastinum, 150 to 200 millicurie is given. And for distant metastasis in the bones and other parts of the body, usually more than 200 millicurie is delivered to the patient. Instructions after RAI treatment includes increased fluid intake, eating citrus fruits and sour flavored candies. This particular instruction is given to stimulate salivation and lower the risk of parotiditis and sialadenitis. Maintaining distance from pregnant women and children below 12 years old. Actually, the rest of the instructions here are quite self-explanatory. I would just like to emphasize now that for the last instruction, that the pregnant women who underwent RAI therapy should avoid getting pregnant for 6 months. These are usually hyperthyroid patients who were given low doses of radioactive iodine treatment. But for patients diagnosed with thyroid cancer and being given high doses of radioactive iodine treatment, pregnancy is avoided for at least 1 year. This is a post-RAI whole body scan. This is a diagnostic scan usually done after RAI treatment to evaluate the extent of disease. What you will see here is a starburst phenomenon or starburst artifact obscuring the anterior cervical region. You would usually see this in patients who were scanned just immediately after radioactive iodine treatment. So this is more of an artifact, but 3 years ago from the study which I made, this particular artifact is actually a good prognostic indication for a successful ablation of your thyroid residuals or even local or regional metastasis and even distant metastasis for that matter. Nevertheless, if you put the patient in pinhole imaging, the artifact will be eradicated. Hence, you will see here the residuals in the anterior neck. This is now the magnified view of the anterior neck showing at least 3 residuals. This one at the bottom left part of the anterior cervical region is faintly seen. This particular post-RAI whole body scintigraphy naman is a perfect demonstration of differentiated thyroid cancer metastasizing to the different parts of the body. There are iodine-avid lesions in the right calvarium or right aspect of the skull, anterior neck, mediastinum, lungs, right humerus. There are pelvic metastatic lesions here and bilateral femoral lesions. I have here a 34-year-old female who is a patient of mine diagnosed with papillary thyroid cancer back in April 2008. This is a diagnostic pre-therapy scan for me to see. Since she is a stage 4 cancer patient, I would like to evaluate first the extent of the disease to lower the risk of morbidity caused by radioactive iodine treatment. Hence, I decided to do a surveillance scan first before performing radioactive iodine treatment. I was able to see here a residual in the anterior cervical region, as well as metastatic lesions, possibly in the lungs and in the pelvic area. This particular scan is of the same patient wherein iodine 131 was already done. Iodine 131 treatment was already done, showing the same lesions seen in the pre-therapy scan. But take note, there is a starburst artifact for most of the lesions that are seen here. And then after 6 months, another round of radioactive iodine treatment was given to this patient. Again, if I'm not mistaken, it was of the same dose that I have given initially, which is also 200 millicurie. And as you can see, the post-RAI body scan now shows the lesion in the anterior cervical region and a possible rib and lung lesion in the thoracic area. But as compared to the previous scan, there is significant decrease in the number of lesions already. This is now the most recent body scan of the same patient, showing complete resolution of the metastatic lesions that were previously seen. Okay. What you can only see here are physiologic uptake from the nasopharynx, gastrointestinal tract, and your urinary bladder. That ends my presentation. Thank you and enjoy the rest of the evening.
All right. Thank you very much, Dr. Chris, for that very insightful and ionizing discussion. So I think it's better to conclude all what we have learned tonight by applying it to a sample case presentation. So we have actually a case here, and may I also again call all of our speakers to be on the virtual floor. May I invite again? All right. So let's have a case discussion. No? So we have a 41-year-old female, an online seller, presented with a 3-month history of a palpable right anterior neck mass, which moves with deglutition, with no associated pain, hoarseness, dysphagia, or shortness of breath. The said mass or the said condition has also no signs and symptoms suggestive of thyroid dysfunction, such as tremulousness, palpitations, weight changes, weakness, easy fatigability, tremors, or bowel movement changes. Family history: the patient's mother had a total thyroidectomy for a thyroid malignancy 10 years ago. And there were no previous neck irradiation, non-smoker, and no intake of supplements on her social history. Next slide po. So what happened to this patient? No? So ATSH was requested, revealing normal result. The said mass underwent also a thyroid ultrasound, revealing a 3.4 by 3 by 2.9 centimeters solid hypoechoic well-defined mass with microcalcifications occupying mid to the inferior aspect of the right lobe, with a ACR TRADS score of 4. On the left lobe of the thyroid, there were 3 nodules, wherein the upper nodule is 0.2 centimeters, which was cystic in presentation, and at the mid, which measures 1.3 by 2 by 1.1 centimeters, with which is solid, hypoechoic, and well-defined mass, with an ACR TRADS score of 4. And lastly, the last nodule at the left lobe is measuring 1.2 solid hypoechoic nodule with TRADS 4. And so a fine needle aspiration cytology was done, revealing malignant cytology suggestive for papillary thyroid carcinoma. So the histopathology report showed a papillary third carcinoma of the right and the left lobes. The margins were cleared for tumor, and the harvested lymph nodes were negative also for the tumor, with a post-op assessment for T2N0M0 for stage 1, according to the 8th edition of the AJC-CTNM classification. So the plan was to do a post-surgical radioactive iodine ablation treatment using radioactive iodine 131 at 30 millicuries, followed by post-therapy whole body scan, and followed by a maintenance levothyroxine, initially at a dose of 100 micrograms, with a plan to adjust it at the lower limit of normal of the TSH. So anyone from our speakers may give their suggestions or comments with the said case.
Sige, ako na muna. I actually agree with the way this patient was managed. So basically, the patient's age is 41-year-old female, risk factor, family history, and then from the ultrasound finding, it's classified as thyroid 4, and a total thyroidectomy was done. So me personally, I agree with the I-131 of 30 millicurie, considering if we're going to stratify the risk of this patient, I would classify her as a low-risk thyroid cancer and actually a stage 1 disease. So I agree with the management, total thyroidectomy followed by I-131, and then levothyroxine to adjust your TSH goal of probably 0.5. That's the lower limit of normal. And then to answer na rin the question of Dr. Malen on the chat box, how soon should we monitor or detect or check our thyroglobulin level? Studies have shown that your thyroglobulin level reaches its nadir about 3 to 4 weeks after surgery. So this one is a total thyroidectomy patient. So what I usually do in my practice is check their thyroglobulin together with their TSH prior to their radioactive iodine. If I'm going to subject them to RAI therapy after 4 to 6 weeks, so I usually do TSH, TG, and anti-TG antibodies before the radioactive iodine. And then how frequent should we monitor the thyroglobulin? Depending on the risk of the patient, the recommendation is every 6 to 12 months. So we may opt to do the thyroglobulin. The recommendation now, more experts are recommending a suppressed thyroglobulin. So you don't need to routinely withdraw the thyroid hormone, especially if it's just a low risk. So a suppressed thyroglobulin together with their thyroglobulin antibodies and an ultrasound imaging. If the results of the imaging is negative and the thyroglobulin levels are within the acceptable level of less than 0.2 or less than 1 for stimulated, then I will repeat it after 6 months, 2 or 3 determinations that are acceptable. I would be more lenient and probably monitor less frequently. So usually after the second year, if the results are okay, I usually decrease the monitoring of their thyroglobulin to every 1 or 2 years. So that's how I would probably manage this patient.
Doctora, is it really mandatory to do a thyroglobulin and anti-thyroglobulin studies? Kasi di ba most often, pre-op or post-op. Kasi di ba laging almost always mahirap makapagpa-request. It's either financially constrained or the availability of the said tests hindi locally available. Particularly sa akin po sa Bataan, nahihirapan din kaming magpagawa ng test. But for the baseline post-operative, talagang maganda po sana na magpagawa. So what do you think are the presentation of the malignancy that really warrants talaga na to have a baseline post-op thyroglobulin or anti-thyroglobulin for the surveillance?
So for pre-operatively, it is not routinely recommended. Post-operatively, if the patient, there's the capacity to pay for the thyroglobulin analysis, they are recommending doing it post-operatively as a baseline analysis, as a baseline thyroglobulin level. However, I totally agree with you. It's not a cheap determination, and sometimes availability is a problem. So in that case, there are some patients where I might not be able to do thyroglobulin immediately post-operatively. So what I usually do is just, especially for low-risk patients, I just monitor their thyroglobulin at least 6 months to 1 year after radioactive ablation therapy. And then if that is acceptable, I sometimes just do it every 12 to 24 months. So, but it is still recommended because imaging should be okay. However, guidelines still recommend using your thyroglobulin level as a marker of your recurrence or even your persistent disease. I'll take this opportunity na rin to answer some of the questions in the chat box. For the question of Dr. RJ Manso, he was asking regarding lobectomy and the use of diba? I think that's the problem with surgery that is not near total or total. So for example, for subtotal surgery or lobectomy alone, the difficulty is in the monitoring post-operatively. But recently, there are some experts recommending that the absolute value of your thyroglobulin may also be used as a prognostic marker. So for example, lobectomy patients, so medyo you cannot do a radioactive iodine whole body scan on this patient because there's a big thyroid remnant. So you can measure their thyroglobulin level after the surgery, put the patient on thyroxine suppression, and then just monitor their thyroglobulin and anti-TG antibodies. Of course, as I've mentioned, thyroglobulin is just produced by cells of thyroid origin. An increasing level of your thyroglobulin in these post-lobectomy patients is suggestive of a possible increase in the thyroid volume or a recurrence. So you might opt to do in imaging, thyroid ultrasound, and probably do further workups depending on the results of your imaging. So that's also one utility of your thyroglobulin assays.
What about for cases wherein initially the treatment is subtotal or lobectomy, and then the histopathology turned out to be malignant? So the appropriate action should be completion thyroidectomy. However, let's say the patient decided not to do any further surgeries, no? Let's say mas complicated na yung second surgery for elderly, or even patients talaga decided not to do the completion thyroidectomy. Is radioactive lobe ablation has a role in this case? Maybe Dr. Carbonell can answer.
Hello?
Yes, we can hear you, Chris.
Okay. Well, we were able to briefly I was able to discuss this already with Dr. VR, and it would be nice for me to discuss this particular issue from the standpoint of nuclear medicine. If I would be given the chance to treat this patient, I would recommend giving a more higher dose than 30 millicurie, because in my practice, I usually see a lot of patients coming back to me wherein these particular patients were given 30 millicurie of iodine 131 just for thyroid residual ablation. But a lot of patients come back to me wherein the residuals were not completely ablated. Worst case scenario, I've been seeing patients where locoregional metastasis has already been seen, okay, such as lymph nodes from all levels of the neck, and even metastasis to the lungs. And I think a good study that would back me up for this particular stand of mine is a study done by Dr. Tommy Law from PGH. I think that particular study is was made last 2015, wherein papillary thyroid cancer in Filipinos tend to be more aggressive as compared to the other races. And not only that, my extreme endorsement of giving higher doses of radioactive iodine is also coming from the fact that it would be easier to diagnose, to monitor, I'm sorry for that, monitor a patient who were rendered complete ablation after treatment of iodine 131 than monitoring patients with residuals, because you know for a fact that you are having a baseline of a haywire if you have a lot of residuals in the anterior neck from your thyroid.
Maybe, doctor, this more aggressive treatment, no, for the cancers, no, stems from the studies nga, no, na in Asian countries, particularly sa atin din, presents with a more aggressive presentation of differentiated thyroid malignancies. What we usually follow of the recommendations come from the US, no, particularly kasi according to the ATA, if the patient presents with a ATA low risk, which what the patient presents, no, ang initial dosage lang is 30 millicuries, no, but as with the studies locally suggest nga na after 30 millicuries, nagkakaroon talaga ng recurrence of the tumors. And based on your experience, as you stated earlier, you would opt to do a higher dosage kahit na ATA low risk pa siya using the classification. What about for cases of micropapillary, yung mga less than 1 centimeters? According to the ATA kasi, if the margins are okay, lymph nodes are negative for tumor, after completed surgical resection, no more radioactive iodine ablation needed. But what about you, doctor, for micropapillary lesions less than 1 centimeter? Would you still give radioactive iodine ablation treatment?
To answer this particular question, I had a patient just a few days ago who underwent radioactive iodine treatment. She was diagnosed as micropapillary thyroid cancer, and the histology of her malignant condition shows that the dimensions were just ranges from, I think, 0.5 to 0.8 centimeters. Actually, she fell into the area of into the very area wherein it is considered as a gray zone, actually. Okay, very gray area zone. So not only that, since the dimension of that tumor was 0.8 centimeters, it was also seen from the pathologic study that the character of that tumor was unifocal. So if you will base this particular pathological reports from foreign studies or international studies, radioactive iodine treatment is not needed anymore. Okay. However, going back to my personal experience and from the local studies that we had, and in fact, I had a brief chat with the Dr. Rose Bongco in a few days back, and she even mentioned to me that there was also an international study which is based in Canada showing that Filipinos really have high tendency to have an aggressive behavior for their micropapillary cancers. So even though foreign studies would suggest that radioactive iodine can be skipped for this particular patients, I still opt for doing radioactive iodine treatment.
Okay, thank you very much, Doctor. Maybe if we can answer some questions in the chat box. One question from Dr. Aguila directed to Dr. Rose. How often does hungry bone syndrome occur after total thyroidectomy?
Okay, thank you, Beverly, for that question. Honestly, I don't have the exact number, but hungry bone syndrome is a severe form of hypocalcemia. In practice, it's not that common. More common would be a transient hypocalcemia, and usually the hypocalcemia seen after thyroidectomy procedure is relatively easy to correct. Hungry bone syndrome kasi medyo difficult to treat, requiring high doses. So this is more common with those parathyroidectomy patients. No, so in my practice, I don't know with Dr. Cepeda, with the surgeons, if they have seen it, but in my case, I have seen hypocalcemia, most of them transient, although there's a few with eventual permanent hypocalcemia necessitating calcium and vitamin D replacement. But hungry bone syndrome specifically, I don't think I have seen one. So most of the time it's transient, and this incidence of hypocalcemia is usually associated, in what I have seen, usually associated with the size of the primary tumor. So we usually see this in large goiters who underwent total thyroidectomy. Also more common in total thyroidectomy patients. Armand, how about Dr. Cepeda? What have you seen a hungry bone syndrome in your practice?
Only hungry surgeons. Actually, I am diligently trained by my mentor, Dr. Arturo Mendoza Jr., on how to preserve the parathyroids during my total thyroidectomy and to preserve the recurrent laryngeal nerve on all its pathways and branches. So with regards to parathyroid gland, we always protect the parathyroid gland. Even some says, oh, 4 naman yan eh. Pwede mo nang tanggalin yung isa. Okay lang yan. No, we don't do that. We treat each and every parathyroid as if it is the last.
Yes, I agree. I think most of our surgeons, almost all of our surgeons now are detailed in their dissection. So we rarely see this hungry bone syndrome. Transient hypocalcemia, we still see, and it's basically mainly because of the swelling in the operative area, causing limitation in the blood supply, probably to the parathyroid gland. But in most cases, yeah, so it's a parang nalilimit yung blood supply to the parathyroid gland because of the swelling in the area. But most of the time, it's transient, very few permanent. Yes, I agree.
Ako, doktora, sa training ko, I've seen one, pero due to a very
hungry
large...
bone.
Opo, hungry bone talaga.
I haven't seen.
Sa CD, sa charity, doktora, talagang uncorrectable yung kanyang calcium. Due to a very large secreting parathyroid adenoma of more than 3 centimeters, and it turned out to be malignant.
Okay, so that one is secondary to a parathyroid adenoma, but not secondary to a thyroidectomy procedure. Yes, not secondary to a thyroidectomy procedure. Thank you.
Okay, another question from Dr. Espinosa. How do you correlate subclinical thyroid function test among patients with a thyroid nodule, and how do you go about it? It is directed to Dr. Rose again.
Okay, subclinical thyroid function test would be characterized by a suppressed or low TSH, less than normal, less than 0.4, and normal T4. So if you're going to be strict about the diagnosis of subclinical thyroid dysfunction, these patients would be asymptomatic. So sometimes I do see them after hemorrhagic cyst, after sudden rapid enlargement of the thyroid nodule. So what I usually do based on the guidelines, the recommendation is to do a thyroid scan, a radionuclide thyroid scan for patients with suppressed TSH. Unfortunately, especially in our local setting, it is not available in Olongapo. The nearest would be in Pampanga. So if I cannot do a radionuclide thyroid scan, what I usually do is just monitor. I would repeat it after 4 to 6 weeks. Treatment, I would look into the profile of the patient, look into the symptoms. If there's no symptoms, heart rate is okay, no weight loss, I will not give treatment, and then just repeat the thyroid function test after 4 to 6 weeks. Sometimes I see them in hemorrhagic cysts, yung biglang laki, na pag tiningnan mo, purely cystic. On ultrasound, it's purely cystic. So sometimes during the first few days after the cyst occurrence, I would often see their TSH to be on the suppressed or slightly below normal. But eventually, with monitoring, there is normalization of their TSH, even without treatment.
What about, Doctora, for normal thyroid function test and nodules, no, na not suspicious for malignancy? Because I've seen doctors din po, no, giving levothyroxine to, in a way, suppress or shrink the nodules. What's your take po, doctors, with regards to the
is this for benign thyroid nodules?
for benign, Doctora? Yes.
Yeah. This is actually a controversial area. I mean, most guidelines would not recommend giving thyroxine suppression, although there are small studies that would recommend lowering down your TSH to slightly below the normal level or even the low normal. Actually, depending on the profile of the patient. So usually if the TSH is already low to begin with, I do not start levothyroxine. For example, TSH of 0.7, 0.8. But if the TSH is on the upper limit of the normal, 2, 2.5, 3, I would occasionally start these patients on trial levothyroxine suppression. Also, the concept of levothyroxine suppression therapy in benign thyroid nodules is thought to be associated with the degree of iodine deficiency or iodine sufficiency. Philippines,
Endemic goiter.
yes, endemic goiter, diba? So we were previously classified as an iodine deficiency, slight iodine deficiency country. Pero I think recently in the past 5 years, medyo gumaganda na yung iodine iodine sufficiency state natin, and the areas with iodine deficiency are just limited to those in Mindanao and I think in Visayas. So mostly, especially in Luzon, majority are already iodine sufficient. So that's how I usually do it. I give it a trial, but of course I explain it to them. And I usually do this only if there are no suspicious features on ultrasound. Of course, if there are suspicious features on ultrasound, I would still recommend doing biopsy. And if, for example, there are some patients who are really not agreeable to a surgical procedure, I would tell them if the biopsy is benign, I would tell them that this is an option, and I usually give it for a period of 6 to 12 months. And then reassess after that period. Do a repeat ultrasound. If there is growth of the nodule, then I might request for a repeat biopsy or even surgery if the features of the nodule are suspicious.
What about for the size, Doctora? Kasi some says kapag less than 1 centimeter, you can give for the suppression. Pero kapag beyond 1 centimeters, almost hindi na tatalab yung suppression ng levothyroxine.
Actually, ako nga, recently, I came across an article wherein they are recommending active surveillance for small nodules. Even I think it's by a group of Japanese endocrinologists. Japanese endocrinologist Ito et al. And then another group from Sloan Kettering Memorial Center in US. They are actually recommending active surveillance for cancers, even papillary microcarcinoma less than 1 centimeter. So ako, what I usually do if it's less than 1 centimeter, low risk patient, less than 55 years old, sometimes I don't give unless their TSH is above 2.5. So my cutoff usually is 2.5. And if their TSH is 2.5, I just tell them this is the likelihood of it being malignant is less than 5%. We can safely monitor it. Siyempre, merong mga OC na patient. So if the patient is OC, minsan nagbibigay ako, tapos i-monitor ko na lang.
All right, thank you, Doctora. Follow-up question from Dr. Aguila, no? Directed to Dr. Cepeda. Congratulations, thank you. My question is, in patients who will undergo total thyroidectomy, are the parathyroid glands preserved, or at least one gland is preserved to prevent hungry bone syndrome? I think Doctora is telling about iatrogenic hypocalcemia, no? In case of surgery-related hypocalcemia. So, Dr. Cepeda, what's your take for this?
Nasagot ko na yun.
Oo nga.
Preserve all parathyroid as much as possible. Yes. So another question from Dr. Manso. For those select patients who underwent lobectomy, what might change in the monitoring and post-operative? I think, Doctora, no, kapag lobectomy and the histopathology returned malignant, the appropriate action should be completion thyroidectomy. No?
Yes, that's what I usually do. Unfortunately, merong mga ibang patients na ayaw. So I usually tell them kailangan ng close monitoring, and that's where your thyroglobulin and ultrasound monitoring will be helpful. But if they're agreeable, completion thyroidectomy is the recommendation.
All right. Practical application, doctors, in the light of this pandemic, no, the recommendation from the societies is to postpone yung elective surgeries, particularly in nodules that presents to have a somehow low risk of malignancy. So what are your thoughts on how to advise these patients who are anxious to do surgery, but since we are limiting face-to-face or surgical procedures, what are your thoughts on advising these patients?
Ako. Actually, you really have to look into the picture, the whole picture. So the age of the patient, the characteristics of the nodule. As mentioned, majority of thyroid nodules are benign, and therefore they can be safely followed up. But of course, there are also some patients who would present late in the disease stage, would present with compressive, obstructive symptoms. For those patients, I usually refer them to the surgeon. Kasi meron naman tayong procedure. They will undergo PCR swab. I think Gordon does 1 surgery per day. So low-risk patients, I often tell them that nodule can probably wait 6 to 12 months. The general nature of the disease is it's an indolent. Actually, if I may share, I have a patient before na thyroid cancer. I did a biopsy and then was lost to follow up. What happened was she went to PGH looking for second opinion. And then PGH, it's a pila. So she, after 3 years in PGH, she also had eventually FNAP, which turned out to be positive as well for carcinoma. And after seeing the PGH biopsy report, she came back to me. Doktora, papa-opera na po ako. That was after 3 years. And when I did my repeat ultrasound, the ultrasound, the nodule size was almost similar. I think it just increased by 1 or 2 millimeter. So this cancer is relatively indolent, but of course it is still cancer. We don't recommend ignoring it. But in some cases, low risk cases, it can probably wait, especially in this time of COVID.
All right. Thank you, Doctor. Another question from Dr. Malen, directed to Dr. Carbonell. How do you handle patients whose primary thyroid tumor was not completely resected because of extension to critical structures?
Firstly, I would recommend for a body scan to evaluate possible metastasis to the other parts of the body, because the clinical picture that this particular patient presents is already an advanced stage for me. So I would like to evaluate first, because if there are metastatic sites in very critical organs such as the brain, in the vertebral column, which compresses the spinal cord, maybe I can offer other forms of local treatment for those type of metastatic sites. However, if we are only what we are only considering here is the huge tumor in the anterior neck, I would suggest that the patient be placed with a tracheostomy tube, so that when radioactive iodine treatment is performed to this patient, possible swelling of the lesion that will compress the airway or your trachea and would definitely give an respiratory airway compromise for that patient would be avoided. So nonetheless, I would go for an aggressive dosing of RAI treatment for that patient. I would just have to do some precautionary measures before I perform radioactive iodine treatment, such as tracheostomy tube installation.
Okay, thank you. Another question from Dr. Mendoza. What about multicentricity or multifocal cancer in more than one lobe? So we already answered this po, from the previous discussion. If one lobe has a malignant lesion, the rule of thumb should be completion thyroidectomy because of the propensity of the other gland to be malignant. From Dr. Eddie Quadra, is FNAB mandatory for this particular case presented with bilateral multiple nodules with TRADS 4? I guess the doctor is telling about if we can skip the FNAB part, given that the ultrasound TRADS scoring is already suspicious or high for malignancy. So in your practice, doctors, do you usually skip the FNAB part, or you go straight away to referring to the surgery, to the surgeon, or straight away to do surgery if the ultrasound findings turned out to be really suspicious for malignancy?
In this particular case, I think the question of Dr. De La Cuadra is the case that we presented, wherein there were nodules on the right and the left lobe, right? And both nodules are more than 1 centimeter. There is one nodule on the right that is THYROIDS 4, and also one nodule on the left that is THYROIDS 4 as well. For this particular case, I agree with Dr. De La Cuadra. I may offer to skip FNAB for this particular patient, since the presentation is a multifocal disease. It is scattered on both right and left lobe, and there is a THYROIDS 4 suspicious nodule on both right and left lobe. And therefore, doing a lobectomy or near total thyroidectomy is probably not a good option for this particular patient. So for this particular patient presented earlier, the online seller, I would still offer it, but I would tell her that skipping biopsy is an option, mainly because of the multifocality of the lesions, suspicious lesions, both for the right and the left lobe.
All right, thank you. We have one last question from Dr. Manzo. do you routinely give prophylactic calcium supplementation after total thyroidectomy?
Yes, it's in one of my slide because of the effect of your TS chronic. Remember, this is a long-term, lifelong TSH suppression. Sometimes after 5 years or 10 years of demonstrating good clinical response, we may opt for a more conservative TSH level of 1. But this is still long-term, lifetime calcium, long-term levothyroxine treatment. And this long-term TSH suppression will have its effect on the bone. It will increase bone resorption and thereby increasing possibility of osteoporosis, especially for our elderly patients, as well as our postmenopausal patients. So if there's no contraindication, giving of your calcium supplement and vitamin D is recommended for these patients on chronic TSH suppression. Thank you.
All right, Doctora, thank you. So follow-up question, no, from Dr. Mendoza. Concerning is doing lobectomy if there is a significant incidence of multicentricity or bilaterality. So why do not do total thyroidectomy outright rather than going back to do completion thyroidectomy? Yes, doctor. So as what Dr. Bongcos mentioned earlier, if the ultrasound findings gives us an impression or suggestive of bilateral presentation of suspicious malignancy, then the procedure of choice is to do total thyroidectomy na po talaga. All right. Are there any more questions? Maybe there's one last po, no, for Dr. Carbonell regarding what do you think are the parameters to say that a differentiated thyroid cancer or carcinoma is having a radio resistance na po, and a succeeding additional radioactive iodine is no more of help in a certain patient?
An important diagnostic tool to utilize for this particular scenario is doing an iodine 131 body scan. And if you have already performed that particular scan and you are able to see the lesions or expect lesions somewhere in the body that are not radioiodine avid anymore, this is already a form of resistance. And not only that, if you have been doing multiple treatment of radioactive iodine therapy for this type of patients, and the lesions or thyroglobulin level are not going down, okay, that particular patient can be classified already as resistant to radioiodine treatment.
All right, thank you, doctor. So I guess that's the last of the question. So it's been a very fruitful evening to have you doctors to discuss the multidisciplinary approach, no, to thyroid cancers. And I would like also to thank everyone for keeping logged in despite we already having 3 hours, no, almost of this presentation. So that's the end of the presentation. May I go now back again to Dr. Maricar for the
Thank
closing.
you, Dr. Villar. Thank you to all our speakers, Dr. Rose Bongco, Dr. Armand Cepeda, and Dr. Chris Carbonell, especially to our moderator, Dr. Ryan Villar. It was indeed a very comprehensive and informative lecture. Now, truly mind-blowing. Truly, thyroid cancer management is a multidisciplinary approach as manifested by our speakers or expert lecturers. Again, thank you for imparting to us your invaluable knowledge. Next time siguro po may med and rad on ko na. Parang postgrad ngayon, seminar eh. Now, some reminders po to all our OCMS members to please pay your annual dues and look for our OCMS treasurer, Dr. Joseph Castillo. And for all those who want to extend their help by purchasing our merchandise item to fund our activities, please feel free to PM me. And also, I would like to take this opportunity to thank everybody, especially for those who stayed. Maraming salamat po sa inyo. And to our sponsors, Sir Phil from Katay and Ma'am Lizette from work. Unfortunately, they will not be able to be with us tonight. And now for our finale. May I call on our Vice President of Olongapo City Medical Society, Dr. Jerome Michael Acosta.
Hello, good evening, everyone, and I'm sure you're all used to me giving all these closing remarks for the past week. So again, I'm grateful for all of our three speakers and to the moderator, Dr. Bongco, Dr. Cepeda, and Dr. Carbonell, as well as Dr. VR, and to our host, Dr. Maricar. Thank you. It is a multidisciplinary lecture indeed. This topic is very close to my heart because of my dad had insular cell thyroid carcinoma exactly 10 years ago, and he passed away after 3 resections and radioactive therapy and all of that. So it ended up being very aggressive. But seeing all of these treatments, all of the updates is very refreshing, and so is trying my hand at the case. So it was all very helpful, and I hope to see you again on our next cancer prevention advocacy seminars and webinars. Until then, allow me to close this once again. Have a good weekend, everyone, and God bless. See you soon.
Thank you. Thank you.